team at Stanford Hospital, as well as in our outpatient palliative care clinic in Palo Alto. I'm also very honored to be here with this group tonight, and thank you, Dr. Jiao, for inviting me to join to talk about palliative care. I will pass it over to Lisa.
Hello, good evening, everyone. My name is Lisa Mooney. I am a Huntington's social worker. I work for the Northern California Huntington's chapter, and I'm also the social worker at the UC Davis Center of Excellence. And um, palliative care is one of those things that I've been talking to many of you on here about. Sometimes it's really confusing. Even I get confused. And I heard Dr. Jiao speak. I don't know, a year or so ago, and I was like, oh my gosh, we need to do this. And Mara had a speaker too, and we've talked about this before. Anyways, this is just a topic that I really am passionate about, and I just think can help us all, even outside of the HD world. And so I'm just so happy that we were able to put this together and get some information out there for everybody. So Mara.
Hello, my name is Mara, and I am a genetic counselor. My quote unquote real job, I guess, is I work at Kaiser Permanente. Been here for 30 years. I run the Huntington's disease partner center of excellence here. And then I also work with Lisa on Fridays at UC Davis, working with families around predictive testing, or if they're new to Huntington's disease world, just explaining genetics and things like that. And I am super happy we can able to pull this together.
Wonderful. I'm so happy to be part of such an exciting team and passionate group of people. As I said before, today will be part one. So we will be introducing a lot of concepts, including talking about palliative care and going over some sample cases of how palliative care can be helpful to you and your family on your journey with HD. So just to kind of take a zoom out, when we think about, living our best life, I imagine that many of us think of scenes similar to these pictured here. Being surrounded by friends and family, enjoying good food, being active, being outdoors, maybe participating in our faith communities, caring for loved ones, caring for our pets, contributing in our jobs, our work. These are the things that bring joy and meaning to our lives. As a doctor, I see that unfortunately for some people, illness can get in the way of us living our best lives. Illness can create challenges that make it difficult for us to access joy, meaning, or purpose. And those challenges can be physical, yes, and they can also be psychological, emotional, practical, financial, even existential and spiritual. So we're here today to talk more about how we can recapture some of that quality of life, that joy, meaning, and connection, even while living with a difficult illness like Huntington's disease. Over the course of this next hour, we will talk about an approach and medical specialty that focuses on making life as good as it can be. Certainly, I know some questions might pop up along the way, and I want to reassure you that we will have time at the end to answer your questions, as well as attend to the questions that you submitted during registration. Today, we will cover the following topics. What is palliative care? How is palliative care different from other parts of medicine? When and how can someone benefit from palliative care? How does palliative care help people do hard things? And we'll start with the big one first. What is palliative care? And I'll turn it to Grant.
Oh, thank you so much, Jocelyn. And I'll just invite everyone who's on too to think in your own minds, what comes to mind when you hear the term palliative care? And kind of as we're going along, you can kind of compare what we're saying to what you think kind of before hearing more from us. I'm a little curious if anyone would feel brave enough to maybe either unmute and say what comes to mind, or maybe put in the chat some thoughts that come up when you hear the term palliative care. I see. Oh, go ahead, Len.
I think of it as easing pain and burdens when there's no cure in sight.
All right, great. Thank you, Lynn. So easing pain, burdens.
Someone
Other
put in
thoughts?
the chat, hospice comes to mind when I think of it.
Yeah, hospice and palliative care, two concepts that often come up right at the same time. And I hope by the end of today, we will learn more about what palliative care is and how it is different than hospice. It's something different and separate from hospice. So we'll talk more about that. Any other thoughts come to mind for folks? No worries. Well, let's go on and we can kind of do a mental exercise at the end to revisit this question about what comes to mind when you hear the term palliative care. So when people ask me to talk about palliative care, I often start by thinking about how is palliative care different? And how is it different from maybe other medical specialties or other doctors or other clinics that people might be familiar with? And one of the things that I think about is that palliative care really centers on thinking about the person beyond the disease. And, this is a sort of a simple shift of the mind. But one example of that is that, other people might think, oh, this is a Huntington's patient. Well, we might say this is a patient living with Huntington's, or this is a person living with Huntington's. And it's just that simple change of phrase where the person is first. And this is a person, a family that just happens to have this disease. And so that's just a quick intro to the difference in kind of the framework that we think about in palliative care. Another way I might answer the question, how is palliative care different from other teams or other doctors that I see, is shown in this model here, where again, that individual with the illness, as well as their family, whether that's biologic, chosen family, friends, caregivers, are really in the center of our care. And in palliative care, we really understand that a difficult illness like Huntington's can certainly affect the body, and there can be physical symptoms, but it can also affect the mind, the emotional state, the psychological well-being of someone. For some individuals, there might be spiritual concerns, or sometimes in palliative care, we doctors call this existential concerns, but that might be things like, why is this happening to me? Or how do I make meaning of this? What's God's plan in all this for my life? Practical or social support might be stressed, getting around, maybe needing a handicap placard for the car, financial concerns about how to pay for treatment or getting to and from treatment. And so I sort of put all this out here just to say that palliative care really tries to understand that an illness can affect all these different aspects of life. It's not to say that neurologists, primary care doctors, other doctors, and other clinics don't understand this. It's just that this is the focus of palliative care, and all of our training is really focused on understanding that all these complex aspects of life interact with each other and all need some attention. One way we try to address all those different aspects of life that can be affected is by working in an interdisciplinary team. So I'm one of the doctors, and if you come to my clinic, you would sort of see me on a video visit or in person, or one of our advanced practice providers like nurse practitioners. And one of the things that the physician on the team might do is really work on prescribing medications, perhaps to ease those physical or psychological symptoms, helping navigate medical decisions. So thinking about maybe different treatment options, um, we might wrestle with those questions. And then I spend a lot of my time actually on the phone and email with other doctors, trying to coordinate care. Sometimes there might be a lot of different teams working on an individual case, and coordinating among all those different specialties sometimes helps make sure we have a really cohesive plan together. We work with social workers who help provide emotional support. That support extends to that chosen family or caregivers or biologic family. Sometimes people need medical equipment or helping to address those financial concerns we mentioned earlier. Our team also has spiritual care providers, or also known as chaplains, who might offer prayers and blessings to wrestle with together with some of those bigger questions that might come up for a difficult illness. So we've talked about how palliative care might be different from other doctors or other clinics or groups of medical providers you've worked with in the past. And I just want to provide this definition of palliative care to try to put a lot of these ideas together. And this is sort of the most accepted definition from a big group that helps organize palliative care providers. So let me just read this definition, and then we'll break down some of these items in the subsequent slides. So palliative care is specialized healthcare for people living with a serious or difficult illness. And this type of care is focused on providing relief from the symptoms and the stress of the illness, really getting at what Lynn was saying a little bit earlier. And the goal is to improve quality of life, both for the individual or the patient with the illness and the family, again, family caregivers. And palliative care is provided by a specially trained team, like we just talked about. And palliative care specialists work together with a patient's other doctors. So we work right alongside a neurologist, a primary care doctor, or for some of our other patients, their cancer doctor or their heart doctor. And we work to provide an essential and extra layer of support. This last point, I think, is really, really important for everyone to pay attention to, and that's that palliative care is based on the needs of the patient and not on a specific prognosis. Again, not related to the prognosis. So it actually can be appropriate at any age or at any point in a serious or difficult illness, and absolutely can be delivered alongside even curative treatment, especially thinking about individuals we see who have cancer. Sometimes we see people who could be cured from their cancer, and they're going through just a really rough spot, either from coping or from difficult symptoms. So again, it's not prognosis related to prognosis or how treatable or not treatable the illness is. I've said this phrase serious illness several times as we've been talking. And, if I get a mild cold, it's a serious illness to me. My partner can attest I'm no fun to be around when I have any type of sickness. But here in palliative care, we're thinking about serious illness as an illness that might have a really big impact either on someone's potential lifespan or kind of their quality of life. Again, thinking about those multiple aspects of life that can be affected by an illness, when multiple of those aspects could be impacted by an illness, that's a serious illness in our eyes. A lot of common diagnoses we see can be cancer, heart disease, and certainly neurologic illnesses like Huntington's disease, Parkinson's, ALS. So a lot of different diagnoses. We talked about providing relief from the symptoms and the stress of an illness. And here are some of the really common symptoms that we might be managing in our clinic: pain, difficulty breathing, muscle spasms, having increased saliva or drooling, irritability, anxiety, depression, just coping. Again, kind of stress of going through a difficult illness. Fatigue, low appetite, and then caregiving on here again, because we understand how important it is for the supports around someone to also be taken care of and to make sure those are sturdy. So how do we relieve symptoms? And if I think about a problem like pain, for example, pain's really complex. There's all these things that go into the experience of pain. In medical school, I learned about how if there's tissue damage around a nerve, the nerve sends a signal up to the brain to say, "Ooh, ouch, there's a problem going on here." And that's one component, but we also know that the brain sends signals back down to that nerve to interpret those signals. So if I'm feeling really stressed or anxious about something else, that perception of pain is going to go way up. But if I'm really in a calm space and maybe even use some calming techniques psychologically, I might bring that sensation of pain really far down. And that's just one example, but most symptoms that people experience uh, have that same milieu of things that contribute to how you experience them, your emotional, psychological well-being, as well as the physical process going on. And so we take that understanding and apply it to treatment. We can use medications to help treat a symptom, but we also know that those can be bolstered by psychological techniques, relaxation, stress relief, meditation, integrative techniques, acupuncture, massage, spiritual support, prayer, mantras, again, meditation perhaps. So when we think about a care plan for someone, we think about how can we integrate and use all these different tools in our toolbox to do our best to get a symptom under control. All right, so coming up next, we have a few cases with some symptoms, and we'll talk more about how we might take a palliative care approach to managing them. So let's read about Ruby in this case. So Ruby has trouble sleeping. She tosses and turns, trying to fall asleep, sometimes for 2 hours. She wakes up and needs to urinate frequently. In the dark, she feels less steady. Sometimes she turns on the TV and watches it until she falls asleep. I'm guilty of that one too. Sometimes she sits in the dark and her mind turns to worrying about her sister's health issues. Okay, so we've got a lot of things going on, and I'm curious from the group, what are some of the factors impacting Ruby's sleep and ability to cope? We've put a few here on the slide, but do people have other thoughts listening to that story about what might be going on for Ruby and her sleep? We can maybe look at some of the things that are here on the slide, that poor sleep hygiene. And, that's sort of the medical term for, think of it as like the bedtime routine. If you think back to even toddlers can sometimes have elaborate bedtime routines, but that's really important to get the body and mind to slow down. Uh, so thinking about, sometimes that falling asleep in front of the TV may not be the best thing because you don't have that time to kind of quiet or calm the mind. Thinking about the environment, is the environment quiet, calm, cool, a place that would facilitate good sleep? Certainly for Ruby, she's mentioned she's having to get up to urinate at night, so that might be something we need to think about. And then hearing more that she's thinking about her sister's healthcare, and so maybe there's a component of anxiety or worry keeping her up at night. So how would we treat this? What's an approach that we might take? And part of it is really addressing some of the things that we heard about. So optimizing sleep hygiene, that might look like making sure the lights are off, that it's dark, that we're not drinking caffeine late in the afternoon, doing something that's quiet and calming, like reading a book right before going to bed. Thinking about fluid management. How much is Ruby drinking and at what time? Maybe getting hydrated earlier in the day and not saving that till 11 p.m. to have 500 milliliters or a big cup of water. Addressing anxiety. So again, using all those tools we talked about, pharmacologic, psychological, integrative, spiritual, to work on anxiety. Thinking about other issues that might be disrupting sleep, maybe sleeping with the window open and it's noisy city streets below. So thinking about how can we really get that environment better. Non-pharmacologic interventions, a lot of people use meditation or apps, music to help them calm down at night. That's an example of that. Taking like a warm shower, if that's something that puts someone to bed. I've even been in the hospital and people actually asked for warm milk because they had this like connection with their brain and tummy that if I have that, it makes me fall asleep. That's a great intervention. And then pharmacologic interventions using things like melatonin or even prescription medications that might help foster sleep. So hopefully that gave just a little bit of an example of this palliative approach. And I'll pass it back over to Dr. Jiao for our next case.
Wonderful. Thank you. Thank you, Grant. So I will take this next case, which will be about mood, and I'll read it aloud. Zachary has been more sensitive to sounds in his apartment. He has been arguing with his sister about when she does laundry or runs the dishwasher. His sister feels that she has to tiptoe around their apartment to avoid making Zachary upset. He's also called the police 1 week ago about music playing at his neighbor's house. Zachary has also developed some sensitivity to light. He's wearing sunglasses indoors, and he does get a migraine once weekly. It's been a chronic thing, but it's still going on. And he says he does not feel depressed, although his sister really does worry about how these kinds of small disruptions are really making Zachary more angry than she expects them to. So again, when we think about the factors that could be impacting Zachary's mood and his ability to cope with his mood changes, there are a lot of things that kind of jump immediately to mind for me. Sensitivity to light and sound is definitely something that many people living with Huntington's disease tell me about, and definitely can be related to the condition. There's also the question of whether or not he might have, a new diagnosis of a mood disorder. We know that people living with Huntington's disease might be less likely to present with that classic low mood, hopelessness, depressive kind of feeling when they actually might be developing a depression diagnosis. So there's a question, is this irritability actually the manifestation of a new mood disorder? Certainly thinking about other things, Zachary does seem to have bothersome migraines, and migraines are associated with sensitivity to light and sound. And maybe Zachary hasn't been, open to treating the migraines before, but would they help kind of temper his irritability, kind of take another approach to helping boost his mood and kind of give him relief? One last factor here that I feel, so many families talk to me about is, Zachary's own difficulty with recognizing what's going on maybe in his body and the changes that he's experiencing, his own difficulty with recognizing and naming these symptoms. I'm wondering if there's anyone else who, has heard of or kind of worked through this kind of issue with their loved one, their family member, who might think of other factors that might be impacting mood.
Yeah, my dad has Huntington's disease, and I have the gene for it, but I'm like either pre-symptomatic or just gene positive. And I have these symptoms too, like the sensitivity to light and sound. But I'm also diagnosed with Irlen syndrome, which is a sensitivity to light. So it's confusing. Sometimes these are confusing. Yeah.
It can be super confusing because, much like even in this case, which is actually based off of one of my own, people that I've worked with, there can be other medical conditions going on as well, right? This person has untreated migraine that could be contributing to these symptoms. And sometimes it becomes really tempting to kind of want to consolidate and say everything's related to Huntington's disease. But then I think, what I'm trying to emphasize here is then we're kind of leaving stones that could be, like turned over to give us new ways of approaching the problem. And that really brings us to, what is kind of the palliative approach to mood? First and foremost, we really do try to be very direct. We want to recognize the importance of mood. So many people tell me that they don't feel like maybe mood is something that they should be discussing with their providers, or it's not important enough when they're there to see their neurologist for something else. And, I just want to be able to kind of really, really, push against that and say that we know that mood contributes so significantly to quality of life for many people, virtually everyone. And so sometimes part of the palliative approach is to help people name when something is going on and really contributing and making it a priority, giving it that time and space and energy to work on. To address these changes in mood, of course, there are many potential psychological interventions out there that have been studied in treating depression and anxiety. Among those, there's cognitive behavioral therapy, which is usually kind of a kind of limited number of sessions to accomplish a very defined goal within those sessions. There's also more supportive or psychodynamic therapy, which is about kind of exploring the roles of prior important people in your life and how you might be reenacting those dynamics in your current life. So there are all sorts of different psychological interventions. And often I think the palliative, approach is to make room for potentially the help of those disciplines. Mara, I see you raise your hand. Please go ahead.
Okay, let me lower my hand now too. So one of the things as you're speaking about this that's really striking me in that work that I do with all the families that have Huntington's disease is there's certain people that have a lot of stigma around depression and mental health issues. Maybe some of it's cultural, I don't know, maybe some of it's societal. I do feel like, unfortunately, our kids in school aren't taught about emotions, don't know the words to describe what they're experiencing and feeling. And I just feel like there's a big education piece that we in our clinic sort of take in very small increments, to sort of move people along to the point where maybe you'd like to try some therapy at some point, or consider these medications that might help. But I have seen, like people just completely turn around their mood using exercise, medication therapy, whatever they use, and that suddenly they manage their symptoms so much better. So that's all I have to say.
Absolutely. Yeah, no, thank you so much for kind of bringing in that perspective. I completely agree that for so much of, medicine's history of mood has been to stigmatize it and to tell people that it's, different from a medical problem. And yet we totally understand now that all of these different issues are completely intertwined and that the mind and the body are not as separate as we like to pretend it is. Mara talked briefly about medication. So certainly pharmacologic interventions are something that I discuss with my patients in clinic, thinking about trying something from a medication point of view to help people with their quality of life. And certainly Dr. Smith can comment on this too. Dr. Smith and I are not psychiatrists. And so, often we will, be able to then connect people to someone, to a psychiatric provider if we think that their mood issues are really difficult to treat. But since we know mood is so impactful on quality of life, it is something that a lot of palliative care providers will at least address. One thing here that I left was which I felt was particularly salient for people and families with Huntington's disease, is thinking about also adapting communication styles. Right? We recognize that Huntington's has a lot of different symptoms, and there are many different things about your mind and your body that are impacted by the disease. And that includes communication. So yes, in this example, Zachary might be more irritable because he might be developing a mood disorder. And at the same time, for his sister, who we don't know if she's also affected as well, part of being able to support one another through a difficult time is figuring out how to meet people where they are and figuring out how to adapt the communication style you may have had for a long time with your family member to support them through this difficult time. Certainly, like I kind of briefly mentioned before, a lot of what I do in palliative clinic is to make sure if I really do think that there is a really strong component of a mood disorder, to get people connected to resources. Whatever resources that they might be open to, whether it is psychological interventions like therapy, whether it is a psychiatric provider who can provide more medication titration, or even if it's just a more support amongst their community or others who might be able to talk to them about their mood. This next case that I'll move to now is the cognitive changes. Layla works as an administrative assistant at a school, and she is noticing more issues at work. She has a hard time listening to her supervisor and taking notes at the same time. Layla has forgotten to attend 2 important meetings, and in the meetings she does attend, she notices that her speech has become more halting. She received feedback that an email she sent to a parent was impolite. Her coworkers stopped inviting her to happy hour, and she's really not sure why. And Layla's getting more worried that she's going to get fired. So what are the factors impacting Layla's cognitive changes and her ability to cope with them? I am certainly borrowing so much of my knowledge from, the neuropsychologists I've worked with, as well as the memory specialists I've worked with. There are profound and sometimes even early changes in executive function in Huntington's disease, many of which, are kind of represented in Layla's case here. When people ask me, what is executive function? It's not exactly something that rolls off the tongue. What I like to tell people is that if you can think of what an executive assistant does for their CEO or their boss, it's that person who keeps track of all the nitty-gritty details, manages the schedule, plans ahead, does multitasking, coordinates between different parts of the brain. And so many of the kinds of symptoms that Layla is noticing at work could be attributed to the changes in her executive function over time. There's the factor of impulsivity. We just get a slight hint of it. Maybe, Layla received a really difficult kind of interaction from one of the parents, and in a situation in which she probably would have, taken a beat and showed some restraint and did not engage with, with the parent in this moment, she really just leaned into it, and she was more impulsive than she probably would have been at a different time. So impulsivity is a major part of also people's experience and lived experience living with the Huntington's disease cognitive changes. And there's, we could talk about that alone and perseveration also, I think, for an entire talk. But I'll just leave that here for now as just one of the factors that we can name. One thing that Layla also noticed is, changes in her speech, right? Speech is one of the ways that we really, beyond just communicating content, it's one of the ways we connect with others. And so for many people, when they notice that their speech, something that's been with them for as long as they've been an adult, has started changing, it can really affect how they really interact with others and connect with others. And for Layla, whether it's a result of even just, whether it's a result of these issues she's having and challenges she's having, or even just her own self-consciousness, she's become more socially isolated over time. And we know that that in itself, more social isolation, can lead to people feeling like their cognition feels more vulnerable, feeling like these changes are more overwhelming. Certainly, Layla is worried, right, about her position and what she's going to do if she's continuing to have these challenges at work. And she has anxiety about the future and her place in her workplace.
Dr.
So
Jiao, this is
yeah.
Lisa. I'm just going to add, I couldn't figure out how to get my hand up. I was just going to add that someone brought it up earlier, well, and you talked about last time, just meeting someone where they're at. If someone is experiencing cognitive changes in their workplace and they know they're at risk for Huntington's or they know that they have the Huntington's gene expansion, they might be worried that this is the sort of the beginning stages of HD, which of course it could be, but it also can be, like you were mentioning, depression or anxiety or some of these other things that might be going on as well, or entirely another medical problem, totally aside from that. I mean, let's be real, I've had plenty of cognitive changes as I age, and I am not at risk for Huntington's disease. So, sometimes this can just be a part of life. And so it's important to recognize that if you are scared about this, it's completely normal to be, worried about these things. It does not mean it's the start of Huntington's disease, but if it is of concern to you, then that's the time that you would go contact your care team or a palliative care doctor or a primary care doctor, to ask them about, what are some of the things we can do to work with to help them to help you.
Yeah. Hi there. Oh yes, thank you for muting. I appreciate that. Thank you so much for expounding more on that, Lisa. I completely agree, especially for people who are pre-symptomatic, especially for people who have a loved one affected by Huntington's disease, and maybe they don't know the status of their own genetic expression. There can be a lot of doubt and worry when they start to notice changes. And I completely agree. Cognitive changes are essentially non-specific. And in retrospect, sometimes with, a genetic diagnosis of Huntington's disease, people can pinpoint, in the past, when I was experiencing these symptoms, they really were the start. But without, any context whatsoever, there are many other kinds of medical conditions that we want to consider. So what is the palliative approach to cognitive changes? First and foremost, again, we're going to return to this throughout the talk, identifying sources of support for that person, whether it's their friends, their families, their employers, someone who can be a source of support for them as they navigate what these changes may represent. Maybe their care team as well, to help them get some clarity of whether they're related to their Huntington's disease. The neuropsychology testing is a mouthful, and so that's why I like to be very clear and tell people neuropsychology testing is usually cognitive testing. Even though the word psychology is in neuropsychology, neuropsychologists are not therapists. So their role is really to assess people systematically on the status of their cognition. And the kind of testing that they do is very in-depth, usually requires at least an hour to get through all of their different tests to test the different cognitive domains. It's much more in-depth than sometimes the screen that your primary care doctor or that your neurologist might have time to do in the clinic. And so often I will say to people that cognitive testing really is the thing that we lean on if we want to look and see what the pattern may be due to. So is this a pattern that's consistent with what we expect with Huntington's disease? In order to kind of combat or, cope with these cognitive changes, there are a lot of seemingly simple and yet really effective interventions that my neuropsychologist colleagues will recommend. Setting a routine, making things as similar from day to day as possible. Again, with that executive assistant being affected, if you can maintain consistency and routine, the habit itself will be protective over time and keeping people organized and on track. Using reminders, checklists. The great thing about how much technology we have in our lives these days is I know everyone has a smartphone. And so everyone has an alarm with them these days. And so reminders on your smartphone, on your smartwatch can be so helpful in remembering to do things that are important, like doctor's visits, taking medications, making sure to check in at work with your boss, just kind of leveraging all of that technology that we're constantly attached to. So it kind of can serve as your executive assistant and to be that part of your brain. I like to also tell my patients, set yourself up for success. Do one thing at a time and try to minimize distractions and multitasking. When you have executive dysfunction, it can be very difficult to shift from one task to another. And that's why it can feel much more overwhelming when people are multitasking. So I tell people, set yourself up for success, set aside a block of time that you're going to get something done, and then keep doing it until it's done, or like set that time that you're going to work on that for 30 minutes, and then you move on to the next task, regardless of whether that initial task is done. Speech therapy can be really helpful just to work on the voice itself, that expression of self, to work through the kind of slurring changes or enunciation changes that people notice in their voice. And speech therapy also can give you more hints about kind of cognitive and communication rehabilitation. Certainly, there's a whole talk that probably could cover work accommodations and short and long-term disability. And I was wondering if I could, highlight Lisa to talk a little bit about either or both of those.
If I can figure out how to unmute myself, yes. So for workplace accommodations, you can talk to your Huntington's care team and they might be able to give you some ideas. But there's an organization called Job Action Network, JAN. I think it's JAN.com. And it's amazing because whether it's Huntington's disease or depression or anxiety or diabetes or whatever the illness is, you can actually look up the illness and it will give you a list of accommodations that this company recommends for your workplace. So of course, some of them are going to apply to your workplace, some of them may not, depending on what kind of job you do. But it's a really, really good resource, to the point where it's one of the resources that me and some will use, so that when we write letters for people for workplace accommodations, we will often use this particular website to sort of reference and to make up a work accommodation plan for someone that can work better for them. Short-term and long-term disability. Now, short-term disability would be either a state disability if you happen to live in a state that has short-term disability. California is one of those states, but we do have people from out of state here. So California does have a short-term disability program that if you pay into, you would be able to utilize. For long-term disability, that is through the government, that would be Social Security. So for people that pay into Social Security, they may be able to get Social Security disability. And then sometimes people will pay for supplemental, what we call supplemental insurances. So they'll pay for short-term and or long-term disability through private companies. And that, of course, depends on your job and what you chose to do. But those would be available as well. And then we can obviously get in more depth and more discussion about those. That could be a whole series in and of itself. But if anyone has specific questions, obviously we can answer those for you.
Yes, definitely put them in the chat. We can try to get to them at the end. We definitely have time for questions. For now, we finished our cases for this initial part 1 of this web series. And I want to take us through, beyond symptoms, what are some of the other kinds of things that palliative care teams can be helpful with? So Dr. Smith hinted about this earlier, in addition to helping with managing symptoms, we can help with making medical decisions. So what does that look like? This can include things like advanced healthcare planning, which is an umbrella term that includes conversations about patients' wishes. It also refers to completing certain documents that people have heard of before, like advanced directives and POST forms. We also help with weighing different treatment options. This can include things like helping someone think through whether they want a feeding tube, helping someone decide, is it time for them to transition from home to a facility, helping families prioritize what's most important in their loved one's medical care when time is looking short. As some of you likely know, making medical decisions can be really hard. Making medical decisions in Huntington's disease, when there can be so much uncertainty about the future, and when multiple people in one family can have different perspectives on what's helpful, that makes it all the more challenging. This is honestly my favorite part of my job, helping people weigh the benefits and burdens of treatment options within the context of what's important to them as individuals. One thing I want to emphasize at this point is that it really is never too early to start talking about the future. Knowing that communication can change due to Huntington's disease from that speech point of view, from that cognition point of view, we can talk about treatments in the future when people are able to participate in those conversations fully. And I always like to reassure people, if your values or wishes change, you can always adjust them. We know that values, wishes, hopes, worries, and even personality traits change over time. And I always like to tell people, never underestimate your ability to adapt and experience joy in ways you couldn't imagine before. And, make room for the fact you could be making choices in the future that you wouldn't imagine making now. I'm going to hand it over just to Grant again, Dr. Smith, to talk a little bit about palliative care.
Yeah, so this is just picking up again that final phrase and that definition of palliative care that we were looking at earlier about palliative care being available at any age or at any stage of a difficult illness, and that it can be given alongside any type of treatment. And I just provided some examples of patients that I would see in a typical clinic day. So it could include someone with a new diagnosis that maybe they don't have a lot of symptoms, but it's that part that we were just talking about, weighing different treatment decisions, maybe coping with the stress that comes with perhaps fear of what might come, or fear of the unknown, or managing the uncertainty of what may be ahead. We see people pursuing treatments for their illness, even if it can't be cured, people pursuing clinical trials. And we certainly see people too who are living with their illness and maybe they've chosen not to get treatment, or they're too sick for whatever reason to get the treatments that might be being offered. So it's this full spectrum of patients that we're happy to see in palliative care. And one thing I often tell people, because a question that we get a lot is, well, like, when exactly is the right time? You're telling me all these different time points, and it's something that I don't want people to worry too much about. Because one nice thing about our palliative care clinic, I think most palliative care practices, is that we work together to figure out how frequently we see each other. So you might see someone in palliative care like one time, even just for a consult to get things, started, or to think about a lot of questions that might come in the future. And then we're kind of in your back pocket that if you need us in the future, you reach out and we can set up an appointment. Other people might have a lot of those different components of life being affected, and we might need to see each other every few weeks for several months. And there's kind of everything in between. So it's something that I don't want people to feel like they have to stress about, like, is it the right time? We can always like meet, figure out what the right cadence would be, et cetera. Among our palliative care friends, we sometimes joke around that if palliative care, we could bottle it up and put it in a pill, it would be the next big blockbuster drug on the market. And part of that is because were some studies done, gosh, now about 10, 15 years ago, but it showed, kind of like to everyone's surprise, that palliative care actually could help some people to live longer. And that really goes counter to, I think, some of the popular or predominant thoughts about palliative care, that it's just end of life care, confusing it with hospice, which is not true. And in fact, palliative care can sometimes help people live longer. This was a study done in individuals with lung cancer, but what it showed was that individuals who got palliative care early in the course of their illness and who saw palliative care on a regular basis, that was the group that ended up actually living longer, in addition to many, many other benefits, not just the survival advantage. And then the other group of patients were just individuals who got referred to palliative care kind of whenever their other doctors thought it would be good. Palliative care has many benefits that have been very well studied, and there's just an ongoing, growing body of literature suggesting how palliative care, or having a palliative care team member be part of your team, can improve quality of life, symptom control, better spiritual well-being, fewer psychological symptoms, and greater satisfaction with care. It also ends up that if you're followed by palliative care, often people end up having to be hospitalized less, or if they do go to the hospital and the palliative care team is following them in the hospital too, that they tend to stay in the hospital for a shorter amount of time. And caregivers often report that they feel better supported and there's less burden on them when it's kind of shared with the palliative care team. So it's a question of when to ask for palliative care, and Dr. Jiao, feel free to jump into at any point too. But I tend to think that, if you identify as having a serious or difficult illness, you're starting to face difficult symptoms, you're facing difficult decisions, or just having difficulty coping. Any of these could be a potential, and certainly a combination of them, almost a definite trigger to say, hey, to your current care team, would a palliative care consult be right for me? A lot of people sometimes ask us too, what's the first visit like? What actually happens? And at least at Stanford, I think this is pretty true for many palliative care teams, that we can see someone physically in a clinic. We do a lot of work over telehealth, and some palliative care programs can even see you in your home. at Stanford, if you meet with the palliative care team, you're often going to meet with one of the medical providers, either a physician or an advanced practice provider, like a nurse practitioner, as well as one of the other team members, either our social worker or one of our spiritual care providers. I can't speak to every palliative care team if that's how they operate, but it's pretty common to have both kind of like the medical and someone who has another perspective be a part of that first visit. At Stanford, and I think typical for a lot of palliative care visits, our first visits are at least an hour so that we really get to know someone and get to know the person beyond the disease, like we talked about from the very beginning. And we often do some questions to check in about if there are bothersome symptoms, again, physical, emotional, spiritual, practical, and then really try to get to know someone. So often for me, like the first 30 minutes of my visit is, hey, tell me about where do you live? Who do you live with? How do you spend your time when you're not thinking, when you're not at the doctor's office? What brings you joy? What brings you meaning? Tell me, do you have a spiritual practice that's important to you? Tell me anything else you think that would be helpful for your doctors to know about you. And that's often where we spend at least 30 minutes of our hour just getting to know each other a bit. And then we check in about kind of the symptoms. Common question is who pays for palliative care? And it's typically covered by insurance, just like any other medical specialty. So if you come to see our clinic, you might have to pay a copay if you end up paying a copay when you go see your primary care doctor or a specialist like a neurologist. And it often can be covered by both private and public health insurance. In fact, in California, there's been quite a move to expand access and payment for palliative care service for individuals with public health insurance. And it's always good to talk to your Huntington's disease team to get connected locally wherever you're being seen. The main way to access palliative care is to ask for a referral. That's kind of the best way to make sure that it ends up getting covered by insurance, and good to find a team that is used to working with your other healthcare team members. So asking your primary care doctor, asking your neurologist. If you end up being in the hospital, you can ask in the hospital if they have a team in the hospital, or if they could refer you to their outpatient team. So typically, a kind of internal referral within the healthcare system is the easiest way, although some palliative care clinics will accept self-referrals. So you just have to kind of ask and check around locally a bit. So we early brought up kind of this idea about palliative care and hospice. And this is a graphic that I like to really keep in my head to remember that palliative care is kind of the big umbrella term that encapsulates all that we've talked about so far. Again, seeing individuals at any age or any stage of their illness, focusing on quality of life. I think of hospice as a form of palliative care that really is that care that's reserved for the end of life. And kind of the insurance guidelines or Medicare guidelines around who's eligible for hospice is often for individuals who are in the last 6 months of their life. So it's kind of hospice where I think does have that appropriate association with end of life care, and palliative care is bigger, broader, and can be accessed far, far upstream from end of life care.
Wonderful. So as we start to wrap up, we just wanted to present some local resources. This is a map, of course, of the Bay Area, even though we are so grateful that there are many people joining from outside the Bay Area. We are lucky here to have a lot of great palliative care programs, and this is a map of some of them. It's certainly not a comprehensive list. As a reminder, all patients, all people in the Kaiser system can ask for a referral from any of their providers to be connected to a Kaiser palliative care team. For others, the best way to find a palliative care program near you is to visit getpalliativecare.org. You can also scan the QR code here in the slide right now and to search your zip code. And you can always ask your neurologist for a referral. As a take-home message from today, I hope that you will remember that if you feel you are facing difficult medical decisions, difficult symptoms, palliative care is here to partner with you to improve quality of life. to help you navigate those difficult decisions. There are many online resources out there that can provide you more information about palliative care and its approach. Here is just a short list. And again, for finding a program near you, there's that link down there, getpalliativecare.org. Thank you for all of your kind attention, and we are so happy to take questions for the remaining minutes. We're clocking in exactly right under an hour, so we have plenty of time. I know there's some in the chat at this point that we can go and answer.
Dr. Jiao, I think someone wants you to go back one slide to the resources
Sure.
so they can thank you.
There we go. That's an easy question to answer.
Right. Let's see. The people that ask questions in the chat, if you want to unmute yourself and ask directly, you can do that. Or if you don't want to do that, you can just stay quiet and I will ask it for you. But it's up to you guys. All right, let's start.
How would this work for veterans? This isn't my own, well, it might be my own situation later, but I'm involved with a lot of veteran groups. My particular Huntington's family member she's at the end. She may have a long time to live, but she's in a wheelchair and cannot talk or move or anything. But anyway, what is there specific resources for veterans in addition to the VA hospitals and stuff? Do you know?
Yes, I'm very, pleased to report that many veterans can access palliative care through the VA system. So it's absolutely one of the medical specialties, much like, neurology or cardiology, who are represented in the VA system. I can speak from personal experience working at the VA. It certainly depends on the size of the VA that you're at, as you've already probably noted, which specialties they have, but it is definitely within the system itself to get you connected to a palliative care team.
Thank you.
You're welcome.
Could I just add too, the VA is also very unique too when it comes to palliative care and hospice, that the hospice program within the VA system is, I'm trying to think of the best words to describe it, sort of more liberal in what can be included in hospice care. And so it's actually a really great benefit to be within the VA system for that purpose. There's not as clear or as hard of a distinction between hospice and palliative care or kind of ongoing treatment and hospice. The VA has really been a leader, I think, in sort of palliative care and providing, even at the end, really advanced end-of-life care for individuals.
Lisa, would you mind reading some of the other questions in the chat?
I can. Kay, you unmuted yourself. I don't know if you wanted to ask on your own.
Yes,
Yeah, well, I didn't know if we wanted to talk about the processing issue, the other question about the processing
We can do both.
issues first. Maybe
You want to do that one
okay.
first?
Well, yeah, sure. I
can
really
speak,
appreciate
but
the
that was
talk.
my question. If you want.
Lynn,
Shall I-
okay, Lynn, you go, and then we'll ask Keiko.
Okay, so I'm a pediatric occupational therapist. I work with kids and their families around sensory processing disorder, whether that's part of their neurodivergent profile with autism or whether it's not associated with autism. And I'm just wondering if HD patients ever benefit from occupational therapy services to work on creating a sensory home program for them, if that's ever beneficial. I mean, I know what it is with the kids that I work with, but I don't work with patients with HD.
I think that's a fabulous question. And I'd be curious how one of the adult neuro OTs that I work with would answer that question. In my experience, that kind of sensory reprocessing technique that you're mentioning is not something that they have typically focused on in neuro OT for people living with Huntington's disease. If anyone has experienced otherwise, please do not go quietly into the night and say so. Typically, by the time that we are referring, people to neuro OT in the setting of Huntington's disease, a lot of the focus is on adaptation to different devices, or thinking about ways that we can really optimize their quality of life and help them remain independent for as long as possible. So there's a huge focus on activities of daily living. And certainly a huge focus on kind of working with the family, creating kind of a family ecosystem to set someone up for success. But I would have to defer to anyone with a prior experience or one of my neuro OTs if that's a specific technique that has been studied in Huntington's disease.
Thank you.
I'm going to chime in about just my own experience with Huntington's. So I'm both an OB/GYN physician who's had to retire because of the Huntington's. I took care of my mom, so I was had the experience of being a caretaker, and I currently have symptoms from Huntington's. And I've actually found it very helpful to read a lot about adults with autism in terms of their own description of their experience of different kinds of processing issues, sensitivities, and cognitive issues. And those really helped me flesh out and identify a lot of the processing issues that I'm experiencing, and help me understand them in the context of the kind of typical list of Huntington's symptoms that help me really kind of almost fine tune my recognizing what was causing overload, or what was easy to do, or how to sort of break something more complicated into smaller tasks, or just to avoid things that were overstimulating. So I used that, and I also worked with an occupational therapist who really understood a lot of those things, just to kind of help me figure out how to set up my day-to-day function, or how to move my body in space and things like that, sort of all of that coming together. So I don't know anything about it as a particular therapy, but thinking about those topics I thought was very, very helpful to me as an individual in my experience of Huntington's.
Thank you.
Thanks, Kay. That was great. Let's see. We can also reach out to Dr. Jiao's or other occupational therapists and see what they have to say about it too, and mention it on another series. Kay, do you want to ask your question?
Sure.
Oh.
Let me. Unmasking Autism is one book that is very useful if anybody wants a resource on.
Would you say it was Unmasking?
Unmasking Autism. Yep. And I don't remember the author off the top of my head, but you can look it up.
I'm sure you can Amazon, Google it.
I kind of had a I'll get to the question I wrote down last, but I had one other question that had to do with the executive functioning and the communication issues and the processing issues. And I was wondering, from a palliative care perspective and partnering with other doctors and other medical care providers and patients and their families, how do you help other medical providers think about maybe writing summaries of the discussions that they have on the phone or in person, so that they can help to summarize and have references for patients and their families, sort of give more detail about discussions that the people with Huntington's may not remember themselves, or to kind of prompt or educate other medical providers to do the same.
So I'm just going to reflect your question back to you and let me know if this sounds right to you. Is your question, how do we ensure that there is very clear communication with everyone on someone's care team about these cognitive changes that we might be noticing and talking about in our palliative context, so that everyone who's really on that person's care team is aware of how to communicate with them, or what these cognitive changes are? Is that the question?
Actually, that's a really good question.
Okay.
Because I think it's hard, because people don't necessarily know all the ins and outs. And so I think that that's an important thing. I was actually thinking about more it's in a supporting the patient and the family to help actually capture what gets said in a medical interaction, what gets said in a phone call, to help capture it and write it down and email it to them, or give them a printed copy of a summary of the conversation so that they can look at it and call back if they have questions, and they can help to remember what gets said. I know some providers do that very routinely, but not all providers do that. And I think that it is hugely beneficial when there's sort of a paper record of those conversations.
Yeah, okay. I think the thing that you're really kind of fleshing out and emphasizing in such a helpful way is that idea of using more kind of supportive features that within what we already have in our medical record system to really help set people up for success, right? So knowing that people can have more reminders, or say things written down for them in their patient instructions and their after visit summary, you know, having those extra reminders, having those external supports can be so helpful. When you
even
are
Yep, and even like a summary of, this is what we talked about today, in an email to a patient, something like that.
Right. Yeah. I think, I mean, this is just my own personal opinion, totally my own take. I have been so grateful for really the nationwide development of having, you know, medical charts available to people who want to look at them. And yes, you know, our medical jargon is completely obscure at times. There's a lot of terminology and it's hard to interpret, but I think that's at least a step in the right direction of what you're saying, Kay, which is really having something to refer back to so that people can understand what was actually discussed and covered. I do think there is a huge opportunity, honestly, and a gap in the way that we could more uniformly ensure that all that information in the chart is able to be kind of instantly interpreted into, you know, a conversational kind of tone so that people are able to digest that information in a more kind of it's just like in a way that they can understand and accept and be able to share with others. And at the same time, I think I recognize that, you know, there's a lot of room for improvement for that. It's something that, you know, as palliative care providers, we could also do a much better job at, I think, in general.
Hey, I mean, I can't speak for all systems, all health systems, because obviously they all do it a little differently, but I think Mara will probably interject as well. I know at UC Davis, we do what we call after visit summaries, which I think health systems in general do. Now, not every provider is going to summarize exactly what they talked about and or provide the resources. We do our best. Can we do better? Absolutely. But a lot of times, you know, especially with like sleep hygiene or some of the cognitive adaptations that Dr. Jiao talked about, or you know, anything major, you know, other falling factors, balance exercises, some of those things, we have information, basically we call them dot phrases, but that we, you know, can just quickly put in there, and it says, we talked about sleep today, and these are some of the recommendations we have, and we talked about, you know, preventing falls today, and this is some of the recommendations we have. Now, can we do better? Absolutely. Is it perfect? No, but I think also asking providers, because I honestly, if you asked me for a summary and said, hey, could you give me a summary of what we talked about today and put it in writing, I will 100% do it. Do I always think of it? No, because we have, you know, 85 things going on. But I do think that as providers, we can do a better job of offering it. But I also think as patients, myself included, we should also advocate that if that's something that you like and would need, then please ask for it, because I think all of us as providers, at least here today, and many providers in the Huntington's community would be willing to do that for, you know, our families as well. Mara, what does Kaiser do?
Yeah, we do have, you know, I have a template, honestly, that I use that provides a lot of the basic things that everybody asks about, like sleep and that kind of thing. And so it's not as like tailored as what you're describing, Lisa, where you plug in, this is the issue we talked about. But I do make a section that just says, these are the recommendations from the neurologist, from the physical therapist, this is the social worker, you know, and I have those kinds of, but could I write more clearly? Could, you know, sure, I could always do better. But
Yeah,
yeah,
and
we
I
do have
just
that.
I reflect also on experiences of other people in support groups, and they
Yeah.
when you talk about what they talked about with their doctor, often they don't remember what was discussed, and or they get a major piece of it wrong. And so, just sort of in service of that, thinking about offering it up to patients and encouraging them to ask their other doctors for written summaries, just to like model it, I think would be fantastic for Huntington's patients.
Yeah, I think that's a great idea. Actually, sometimes we've used ours. Mara will laugh about this. Dr. Wheelock, who's since retired, but sometimes we'll say, like, Dr. Wheelock said no coffee after noon or no coffee after 1 p.m. or after lunchtime. And we'll literally write that in the after visit summary so that the care provider can say, hey, remember Dr. Wheelock said, or Lisa said, or Mara said,
Yep, yeah, that's
just to,
perfect.
help the families and stuff. So yeah, sometimes we use it as, another resource for loved ones to, sort of reiterate what was shared at the visits.
Yep, that's great. The other question that I had, and it sounds, Dr. Jiao, like you do a lot of early discussion in terms of decision making with people early in the process. But I was just wondering around talking to people early in the disease process about the fact that because they'll have communication and cognitive decline, it's important to think about really complicated ethical issues and their like end of life wishes and other things early if they want to address it so that they can sort of have better and more complex discussions. And so I just think it's important to sort of lay it out so that people know what other people choose and what people think about or what questions they have. And it sounds like you do that. And I didn't know if other people had approaches to kind of talking about it early.
Yeah, so I will say, the medical decision making piece and kind of projecting into the future and thinking about especially medical interventions that people may or may not want to experience, that they may or may not face. I always find that to be sometimes the most nuanced kind of work that we do. So probably the first thing that I can do, and Dr. Smith can also speak to maybe, his practice. The first thing that I always ask people is, what are your preferences about hearing about the future, about thinking about what the future might look like, what to expect? What kinds of information are helpful for you as a person? And I'll often use the example, okay, I work with very different people, right? And I work with some people who tell me, I want to know everything that the doctors know. I want to know what that little smidge on that x-ray means. I want to know what my creatinine is on the laboratory work, because having more information makes me feel empowered, right? It helps me feel in control, helps me feel like I understand what's going on. And even if there is uncertainty, I want that information, right? And then I also use the example, I work with some people who, tell me the most important thing for me is my peace of mind. And the most important thing for me is how I'm doing in the day to day and how I'm feeling in my body today. And I want to live in the moment. And with those people, I work with them to really elect someone in their life, right? A friend, family member who can really receive information from their providers to help providers make decisions on their behalf, because we can do both of those things. We can respect those information sharing preferences and receiving preferences, and we can still find a surrogate, a voice for that patient, even if they themselves don't want to be the person receiving news. And then I tell people, most people are somewhere in the middle of that huge spectrum, right? And I say, most people tell me, some of the details can be overwhelming. However, I still want my doctors to tell me what's going on with me and what does that mean for me. And so most people tell me they kind of want that big picture. That's the kind of information that they find most helpful. So depending on how people really engage with thinking about this, that really helps inform me in my practice to tailor the kinds of conversations we have about the future. Because, I of course, being a medical provider, I'd like to think that I would want to know everything about the future because I happen to have that information. And yet at the same time, we know that not everyone has that preference.
Oh, absolutely. Yeah. I mean, absolutely. But you're having a conversation about what their preferences are about having those conversations at the
Yeah,
beginning.
exactly.
Right.
Exactly.
Yeah. Do you talk about sort of the dementia coming, like about if they want to have those conversations, now is a better time to have it? Like, do you frame it in that way?
So I think that is a really good question. So when people ask me, am I going to develop this? You know, I have two instincts, right? The neurologist in me wants to answer that question from a cognitive point of view and say, statistically, this may happen over this period of time, and it might look like this, and you might experience this, and just like word vomit information on people. And then my other instinct, right, and the one that I try to really, you know, lean into when I'm being the palliative provider is then just to, you know, reflect with people and say, it sounds like something that you're worried about and that you've been thinking about. And I'm wondering, where is that coming from? Is that something you saw in your parent? Is that something that you fear because of something you read? And I wonder if you could share with me more. Like, what is the emotion behind that question? Because both of those things, the cognitive answer and the emotion answer, are really, really important for us to acknowledge, right? So it depends in that moment, honestly, when I'm face to face with someone, what I think they're actually asking me. Because sometimes when people are asking about the future, right, what they're trying to express is that I'm scared.
Sure.
Yeah,
Yeah.
and I want to know that someone's going to be there to support me, or I want to know what my options might be, or I want to, you know, something else. So, you know, it really depends kind of on the situation. And of course, once I've identified, right, that what the emotion might be, I will then, you know, be like, is this something that you want to talk about now? And then how much detail would be helpful for you?
Great. Thanks.
I may jump in for just a moment too, and I really appreciate, Kay, your question. And I would say that advanced care planning is really important, and especially if there is a risk of losing the ability to answer those questions in the future. That doing that advanced care planning in advance is a good idea. And one thing that we offer at Stanford, I'll pop in the chat, is that we do offer actually free, open to the public quarterly advanced care planning workshops that um, we really invite people to, and we spread the information about these to a lot of places, including even primary care, just for even healthy older adults. This is something that's kind of on the to-do list for everybody who's an adult. So I would just, for those who are interested, these are two-part virtual workshops that the first part is really thinking together about what are the questions to kind of ask myself, to ask my medical team. And then the second part, we go through page by page through a written advanced directive called Prepare for Your Care, which is one of the advanced directives we really like at Stanford. And I think UCSF uses a lot too. So just wanted to put that plug as a resource for kind of anyone who's on this, for yourself, your family, your friends. I think this is an important topic.
And we've got that at Kaiser as well. We've got a really well-developed program.
Yeah, and I think part of it too with advanced care planning is sometimes there is a fear-based, at least I know way before I got into this field, my parents would try to talk to me about, their trust or their will or the what, and it would like, no, you can't say it, otherwise you'll get happen. And unfortunately, that's not really the way the world works. But so it can just kind of be scary. So sometimes it's if this is something you really do want to talk about, certain providers are going to be better than others because of maybe maybe because of their education, maybe because of their own personal values and beliefs and things of that nature. So if you try to approach the subject with a provider that it does not seem to be very receptive or willing to have that conversation, definitely ask for a referral to a palliative care provider or to another provider that might be willing to have this conversation. I know I've specifically had many of these conversations via phone, sometimes via Zoom, with patients and families over and over again, because that's what they particularly needed. I don't tend to get scared. You're probably not going to tell me a whole lot that's going to, make me run away or anything like that. So, but some providers are not necessarily comfortable with it. So just providing those providers that are comfortable with these topics. And if the first one or two or three don't provide it for you, keep searching. Don't give up. Definitely don't give up. Thanks for sharing this, Dr. Smith. That's fantastic. I think UC Davis does these too, but I couldn't give you a link to them. I'll tell you that much. Let's see. We have like 7 minutes, if I can do math, 7 more minutes. Does anyone on the call right now or on the video right now have a question they want to ask? If not, I do have a list that we can go through. Let's see. How is palliative care implemented within an HD clinic? I'm going to let's start with Mara, and then we'll go to Dr. Jiao.
So at our program at Kaiser, we used to have a palliative care nurse that came to our clinic, which was fabulous. But she did discover that she had a lot of overlap with our 2 social workers who were doing a lot of the advanced healthcare planning, talking to people about, trusts and power of attorney, and as well as the advanced healthcare directive, of course. And so she, in the end, decided her services were going to be better used at the ALS clinic, which made me sad, but she went there. And so that's, at this point, we refer people, as needed, and we probably don't do it as often as we should and bring it up. So I'm really grateful for these talks to kind of remind me and refresh me that this is such a valuable service.
I can speak for at least the Stanford Huntington's clinic. So since I started in the fall, honestly, the leaders of the Huntington's clinic have been so enthusiastic about being able to include more palliative support. So we have a unique arrangement where essentially I have an hour blocked every clinic day that the Huntington's clinic is taking place, that first Friday of the month at Stanford. And that hour is really used in the way that the Huntington's clinic thinks would be most helpful. So whether that's actually referring someone to see me in that moment, in that block, I will actually do a full visit with people. But even more informally, even if it's just to introduce myself and have a sit down with people, show my face, talk from my perspective about what I think palliative care can be helpful with, whether or not it can kind of meet the needs or the questions of the people sitting in front of me. It just allows for a little bit more of a personal interaction. Often, I think many palliative care providers experience this. When people are referred to us to a clinic from another clinic, sometimes people will arrive and be like, I'm not really sure what this is for. I don't really know what palliative care is. What's going on? Do they think I need to be enrolled in hospice? And there can be a lot of questions about the referral. And what I really like about being integrated into the Huntington's clinic is that I get to kind of say for myself, right? Like what we might be doing in the clinic, the things we might be working on and talking about. And then I feel like, okay, people have heard the spiel. They kind of get a sense of, who I am as a provider, and they can make the decision for themselves whether or not they want to see me in clinic.
I think that's great. Thank you. UC Davis, we don't have, similarly to Kaiser, right now it's an external referral, which we can 100% do. If you are a UC Davis HD patient, you can always ask, similarly tomorrow, do we always think of it and always offer it and all of that? No, we could be better at all of that stuff. But I'm going to
I will say that's because all of you are practicing amazing palliative care already.
Well,
yes.
I mean, we all have a little bit of that. Amy, I'm going to pick on you. I don't know if you're still listening and you weren't expecting this, and I wasn't really planning to do this, but Amy's from the University of Iowa Huntington Center, and I'm wondering how and if palliative care is integrated into your system or how you guys do that. in Iowa?
You know, the same similarly, and it recently has somewhat changed. It used to be that the neuro movement disordered palliative care clinic was held on Mondays, which was really a barrier to us because our clinic is on Friday. And so when individuals travel in, it's like, it's too much. It's too much to make that trip, especially back to back like that, like if you were there Friday, Monday. So when we really try to pride ourselves on stacking things. So it recently changed there, I discovered, and they will schedule an individual from the HD clinic any day or a Friday, and we could piggyback. Now, the key to that is thinking ahead fast enough and with enough time, like 2-3 months, to identify people 3 months in advance and get them scheduled so that we could piggyback them. That is a nut I still try to crack. Yeah, it's hard to work 3 months in advance. I'm not that efficient. That's pretty efficient. So I've been trying to solve that riddle. What is happening now in practice is because my background is in palliative care, in a prior life before I came to HD, the HD clinic. And so what I'm trying to do is in my pre-clinic visit, do a very thorough 45-minute telephone conversation, teasing out some things, and then talking about palliative care at that clinic visit, and then trying to catch it with a return visit. So that's the best I can accomplish right now. So
that's beautiful. Well, thank you for sharing, even though you weren't expecting to share.
No, it's like,
let's see. We literally have 1 minute with lots of questions. So if you wrote questions down, either those that are on here and or those that will be watching the replay that we didn't get to this time, we are doing a series. This is one of 3 and or one of 4. We're not sure yet, but we will definitely get to these. Let's see. I think I was just going to leave with this question because it's a question we get a lot. Like, what's the best way to do this? Or what's the best way to ensure sleep for both the caregiver and the patient? Dr. Jiao or Dr. Smith, do you want to talk about the best way?
I can try my best at that. Often, you know, I take the easy road out, and I often tell people that there's never any best way to do anything, especially in life, in medicine, right? And that often the kind of plans that I feel like work best for people are the ones that really suit their individual needs and really address them as people, right? Going back to that model of palliative care as like that person being in the center. Often in medicine, people might feel like, you know, a lot of what we do is algorithmic, right? Like if you have this, then the doctor says this. But in palliative care, we really try to fine tune and tailor all of our recommendations to someone's, you know, specific context. You know, how are they doing? What is important to them? What are they most concerned about? What are the kinds of resources that they can draw on? What's available to them? So that's often, I feel like, the best way.
Yeah, the best is really hard because what works for one doesn't work for another. I think we all know that, especially in the HD world. And what worked for one, you know, for 3 months, 6 months, a year may not work, you know, 2 years down the road. So the best is what's going to work for your family or what's, you know, or your family dynamic. I mean, let's be real. You know, I have sleep issues myself, and, you know, for a long time, I used the Calm app, and that doesn't seem to be super helpful for me at this moment, but it's still helpful for my daughter. Anyway, so you kind of, you know, we change as well. So, you know, you kind of have to look at all of the strategies and sort of pick what's going to work for you or what you can consistently do, because that's the other part of, finding best practices for anything is, exercise is the best medicine, right? But if 30 minutes a day, but if you only have 20 minutes a day, does that mean you shouldn't do it? No, of course you should. But, 30 minutes a day might not be realistic for you, or maybe, 25 minutes or, whatever it is. So anyways, just know that best is not necessarily the only way to achieve something and to achieve your goals. And hopefully you guys learned that today. We are technically 3 minutes over time, so thank you all for your attention and for joining us this evening. We don't have a date for our next series, but you will be informed via email and or social media. You can also ask your team, your Huntington's team. I send this to all, social workers and things of that nature. So please feel free to ask questions. Please advocate for yourself. If you would like to inquire about palliative care in your area, you can go to that getpalliativecare.org. Or you can also always ask your Huntington's care team. We will not be offended. You should 100% advocate for what you want and ask for what you want. And we will try to provide that for you and try to get you what it is that you need. And with that, Dr. Jiao, Mara, Dr. Smith, any closing remarks?
Thank you. This is just showing me what a wonderful resource we have here in Dr. Jiao and Dr. Smith. So thank you guys.
Thank you all for
Absolutely.
joining us.
Thank you for having us.
Of course. Thank you all very much. And I hope you all have a wonderful rest of your evening, and reach out as needed for any of us. Okay. Good
Bye,
night.
everyone.
Good night.